Good evening to you all. This is Pranav, and we are set to start the proceedings of the day with deep honor and absolute reverence. I have an honor to invite our two scholarly, uh, established professionals from India who can speak on the subject of diabetes mellitus. This program is in commemorance of my revered late brother, Nikhil Bhai Patak from India. We did not accept any kind of a sponsorship today. We are going live on several timelines, including Dr. Jayesh Sheth, Dr. Navneet Shah. So if in case you have a question, feel free to drop by as soon as the presentation gets over. We will try to take the questions from the timelines as well. This is Pranav, and we are going live on NPF INC Broadcasting. Dr. Jay Sheth is with us. He had been to our program before, and so has Dr. Navneet Shah. So I will not waste any time more for introducing themselves. They are well familiar figures here in North America as well as in India. And today's theme is a bit different. They had an opportunity to do some kind of a scientific work for a very famous herb named Mamejwa, that is Anacostina littoral. That's an Ayurvedic herb. They did wonderful work in terms of conducting clinical trials back home at India. And where the resources are scanty, opportunities are limited, budget are always posing the constraint in which if this kind of a herb can provide some kind of benefits, and they try, why not we should explore that. So Dr. Jayesh Bhai will start the proceedings today with a presentation on Anacostina littoral, and it's an Ayurvedic herb. And we should not forget, dear friends, that the Ayurvedic saint and sagas like great Vagbhat, Charak and Shushruta, they did not have even fasting blood sugar, glucose tolerance tests, random blood sugar testing, glucose testing, glucose tolerance, and even molecular imaging mechanism, even if with the divinity, whatever they wrote in terms of poetic prophecy, even till date today provide us a thought, it provides us an insight where to go and how to move forward. So let us try to explore some kind of remedy through our ancient wisdom that is shared in the classical textbook as well as through the modern medicine. It will be this presentation will be the combination of ancient traditional wisdom plus the scientific innovation, modern gadgets where we could not modernize the complementary medicine. So it will complement the efforts of further modernizing the complementary medicine as well. Dr. Jayashet, it's an indeed honor to have you today with us.
Thank you. My pleasure, Pranav. Uh, Today, first of all, before I start my talk, I would like to acknowledge the entire team. This was a part of the CSIR Nimitli project, is a new millennium initiative technology leadership of India. And under that, at that time, the CSIR DG Raghunath Maselkar was there, and he thought that we have a lot of. You all know that the Haldi we won the case because the somebody in the Western country they try to fight the patent, but we had to. I think take a lot of pain to revert that back. So I think that was a lesson for us. So he started the separate division in CSI with the funding to identify the herbal drugs that herbal drugs works on the degenerative disease. Diabetes mellitus that was one of them. And uh, in India, I would acknowledge Dr. Ashok Bhai Ashwaita, his wisdom, his stewardships to gather 40 centers across the country. Can you imagine all big head? 40 centers across the country. Somebody doing the toxicity study, somebody doing the dossier study, somebody doing the interaction studies, somebody doing the clinical studies. So Dr. Vaidya, Dr. Rama Vaidya, Dr. Ashok Vaidya, and his entire team was there. And I was a part of the PI in charge in Gujarat, and I'm very honored and so privileged that I had a good friend like Dr. Navdi Shah, who was with us at the time in VS Hospital. So there was no doubt for the getting the patients. Always ready to help. Dr. Navdi and Dr. Timin Marwa, he was also to some extent was involved in the study, and we started work on the anicostema. Several drugs have been tested before that, like Nisa Amla ki Amla. We all know that we tell that the Amla also has helpful in reducing the blood sugar or the glycation or glyco-HB. So we tried that also. Then several other compounds have been tried. And then among all these different compounds, Anicostema literally, which is commonly used herb in Saurashtra region to treat fever. So that we found that that gives a good result not only as an anti-diabetic, but also helps to reducing the lipid also. And earlier, Dr. Goel, R.K. Goel, who is now the Vice Chancellor in DIPSA in Delhi, he also had shown some influence of the anicostema in reducing the lipid levels. So with this study, I am honored to have uh, the good clinicians, their collaboration like Dr. Navisa, who is on board today. So I would like to hand over, ask Dr. Nambi to speak on that, how we started it, and then I will show some of the slides in between.
Okay. Thank you, Jayesh bhai. Thank you, Pranav bhai, for making us together. Now, this was a study. I'm purely a modern medicine man, but Dr. Jayesh bhai invited me that we are going to make a study, and we would be needing the patients, and then we had some inclusion criteria, and this was an observational study. It was not a randomized double-blind control study, but as the wisdom tells us that there are some Ayurvedic compounds, they are useful in medicine and they do have beneficial effects and they may not be that costly as compared to allopathic medicines. So I was attracted to that. Then my job was simple, just to find out the patients, right patients, subject them and give it to Dr. Jayesh bhai, and rest of the things we carried out as a team. Believe me, but there are two things which are different in modern medicine versus allopathy. Allopathy looks at a compound medicine. You know, we do not have a purified molecule where we study. And second thing, the allopathic drugs, when they enter into the market, they go very vigorous chemical molecule with double blind, randomized, multicentric, multi-continent study, and after that the drug is uh, proved safe, effective, and it can be also for a longer run can be used in the society. So both the things, most of the times the Ayurvedic medicine when we use, we know that it is since ages people use this medicine or the compound and then they were taken for a very long period of time, they were found to be safe and they were found to be effective. But there were no control studies and this was the study which Jayesh Bhai and we together did was to see the effects of Mamejo or Anacosta laterally for the management of type 2 diabetes. And I think there were many interesting findings during this study we saw, but the most important thing, it was a very safe drug and it did not have any kind of significant adverse effect except for some tolerant issue in some patients. Otherwise, it was safe. The efficacy wise, we will see how much it was efficacy that once Jayesh bhai introduce us to the molecule and then we will talk about that. So I think I would hand over the mic to Jayesh bhai for further deliberations regarding this molecule.
So let me set the screen, Pranabhai. I will just
So
I will share
take your
the screen.
time. We have all the luxury of the time today, please.
Full screen. One moment. Full screen. Wait a minute, why I'm not getting it. So, what exactly we did it? One moment, huh?
No worries, Jeshwai, take your time. This is Pranav here, dear friends. Uh, always technological aspects poses certain challenges when we try to put the house in order. So just stay tuned, and as soon as Dr. Jayesh pulls over the data
So what
from.
what we found, first of all, the in the start we study with the project.
Present screen, uh, present or present now, then present screen, full screen.
Yeah, one moment. That's what I'm doing it.
Ah,
More option, full screen, right?
ah.
Yeah, and then
Share, then share the screen or whatever it was.
yeah,
Share the screen.
get with activities. Go with activities. No, not that. Why I'm not getting it full? Then report. Wait. Wait. Yes, this is what it is. Yeah, present now. Sorry. Full screen. Wait a minute. Entire screen. Yes. Share.
Yes, now you are there.
Yeah. If you look here,
Make it PowerPoint presentation.
yeah,
Ah,
that's
that's
what,
right.
that's what I'm doing.
And make it full screen,
Yeah,
Jeshwar.
it's a full screen I'm making, right?
Yeah.
So, particularly what we did see, we entered in this stage where the compound was identified that this is not toxic or this is really, it has very minimal effect, it has more potential. So that part was done by the other groups, mainly Dr. Ashok Vaidya was the leading one. And you all know that the drug discovery in the modern medicines, if you look at the slides, and development process is very expensive, time consuming. There are numerous bottlenecks. It's like you have to make the target identification, that make the lead identification, then you do the optimization of the compound and clinical studies and the clinical trials, and then drug to market. This takes almost about 10 to 20 years and millions of dollars. But in the reverse pharmacology, this terminology used by Dr. Vaidya was the first time. And reverse pharmacology means here we go in a different way. You have the clinical trials, phase one and phase two, because like we like lot of Ayurvedic drugs we take routinely. So then the clinical trials, phase two, phase one and two, then we did the preclinical studies, and based on that make the drug development and do the relevant science and the large scale science. So that trials. So this is what the particularly the reverse pharmacology. So where you know the compound, people are taking that, so you know that it is not toxic. So you start with the clinical trial and then you do the preclinical studies, and based on that you make the drug development. And once you have that, you do the relevant science and then do the large scale trials for that. So this is the same path we follow with the Mamejua, and you all know that the particularly diabetes is an oxidative stress, particularly hyperglycemic stress. So we know that the balance of oxidative stress and anti-oxidative defense system exists in the body. And that particularly like reactive oxygen species, lipid peroxidase, what it does, that there is balance is very important between these two. Antioxidant and reactive oxygen species is very important. So here we follow those who are type 2 diabetes. They have a lot of reactive oxygen species in there. And so you have to always continuously balance it with antioxidant. Same way for the cancer also, it's a lifestyle related disease. So the whole base of the study is not only that the how much sugar is controlled, but we looked at how this drug is beneficial, the compound is beneficial to help prevent your DNA damage, or to at least minimize the DNA damage, minimize the oxidative stress. So that was a very important part. So that's why I'm just showing that the as a preamble, the cell and tissue damage, we all know that. What happens? Cell and tissue damage by reactive oxygen species is lipid, the protein, enzyme, and DNA. What happens? In the lipids, protein and enzyme, the reactive oxygen species, what they do? They do the injury of the cell membrane and cell components such as lipoprotein. That also, it also damages the DNA, leads to the changes in the DNA, but not mutation, I would say. It produces certain the sister chromatin exchanges, more gap in the chromosomes, and the continuous process, there is no self-repairing beyond certain point. That is the starting point for the cancer. Same way, even for the myocardial infarction, uh, right. In myocardial infarction, cerebral epilepsy, the arteriosclerosis, all the damage of the cell and tissue damage by reactive oxygen species is the is the center point. See, if you look at the development of the drug in the modern medicine for diabetes, we always look only at the sugar. Nobody talk how much your DNA damage is prevented, how much your oxidative stress is reduced, how much it has helped to prevent a cell damage. But this is particularly with Mamejo. In addition to all of the modern markers, like we looked at the tissue toxicity, like the nephrotoxicity, the cardiotoxicity, the particular neurotoxicity, all the parts we have seen. In addition to that, we have looked at the cellular toxicity. And I will say here that it is not the people who die with the high sugar, but it's the diabetic related complications. And why the diabetic related complications? Because of this hyperglycemic stress, there is a continuous damage to the cell. And we have published that paper also in current science, that we have shown that the people with type 2 diabetes, because of the hyperglycemic stress, they have a more number of the sister chromatin exchanges, means chromosome. We have a 23 pair of chromosome. So particularly those with type 2 diabetes have a more number of the gap, more number of the exchanges, and more number of gap in the chromosome, means people who understand that there is a break. So we know that there we have 21,000 genes. Each chromosome has got around 800 to 1,000 genes. So so your particularly the more the exchanges occurs, more your particularly your genetic structures will alter, or your genetic gene will be damaged, or that maybe the impaired function will be there. And this is the center point. Why? Type 2 diabetic people, they had increased risk for the cancer, increased risk for the neuropathy, increased risk for the retinopathy, increased risk for the nephropathy, for cardiomyopathy, so this is the reason why, because that depends on where the DNA damage has, how, particularly during the exchanges, where the damage has taken place. So what we did, this is the study that we have done, the Comet study first. We know normal cell looks like this, but when our cell, internal cell damage, it looks like this. When there is a moderate damage, it look like this, and high damage. This is like a Comet study. So we have done the study in diabetic patients. We do lot of patients with the mild to high damage to the cell. So it is a cellular damage. And then what we found, we have looked at the chromosomes, and you look at these chromosomes, particularly you can see this particularly, these are all these the chromatin exchanges. This is the normal cases, not in the diabetic patients. But if you look here, sister chromatin exchanges, these are the normal cases. Hardly very few exchanges are there. But if you look here, in the diabetic patients, if you look here, they have a more damage. The more number of the damages are there. If you look at the cell also, we have taken the cell from the diabetic patient, we look at the Comet study, we found you can see these all cells, they are mildly or highly damaged. If you have more highly damaged, then it is a very serious condition. But most of the cells are very mild, or very few are moderate, or very few are. But if you look at the genoprotective effect of particularly the compound, the anicostema, we found the cellular damage has been reduced. We also found that sister chromatin exchange has been reduced. So this is very significant point. So forget about how much sugar it has controlled, but how much protective it has on the DNA damage. That is more important. That is a very important point for the anicostema study in humans. If you look at this study, what we have looked at the interactions also, we found that the interactions with metformin, sulfonylurea, because people will see many times people say, okay, diabetic drugs, we don't know because it may have interaction with insulin, it may have interaction with some other drugs. So we did that, and we found that no, the particular the nicostemalitrol or the mabejua has no interactions. So people who are taking the metformin, sulfonylurea, they should continue to take their drugs, and then this is a adjuvant therapy, so add-on therapy. Why add-on therapy? I think Dr. Navneet Bhai, now I ask Dr. Navneet Bhai to speak more on this, and then I will again take over further to show the further slides.
Yes, so what we thought, Jayeshbhai, at that point of time, that the drug may not have a very potent or the robust glucose reducing effect, but the
Yeah.
benefits were beyond that. So we have a modern medicine where you can reduce the blood sugar as per your expectations, but these are the compounds which have been tested for a very long time. They have an additional advantage of chromosomal protection, of antioxidant activity, and host of the things. So the complication of diabetes is not only because of the blood sugar, but then you look at many pathophysiological mechanisms, continuous high blood sugar, glycemic variability, advanced glycated product, and then antioxidant mechanism and all those. So these particular compound we found very two important things. One was chromosomal protection, and second thing was that though the sugar effects are not very impressive, but the glycosylation was really very impressive. So we could see the reduction of glycosylated hemoglobin with this compound in comparison to blood sugar reduction. So there are many compounds like that. They may not apparently be very robust or very potent effectivity against the particular problem or a disease, but then they have an other supportive mechanisms and additional benefits which could be good for the health. So in this study, which ultimately we found out that it is good for prevention of chromatin damage, it is good for prevention of glycosylation, in turn leading to lesser complication of microvascular complication of type 2 diabetes. So I think we must look at the overall perspective of the compound, and we must not just say or negate that no, 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 it doesn't produce reduction of HbA1c like insulin produces or a sulfonylurea produces or a metformin produces, but the reduction of HbA1c alone is not the thing which we should target in type 2 diabetic population. Jayesh bhai.
Yeah, that's true. So that's why you can see in the slide, Navneet Bhai, there was a reduction in the fasting blood sugar, the postprandial blood sugar is not that remarkable. There was a more, the HbA1c, there was 13.5% reduction. Fasting blood sugar was a 10% reduction, or PPBS was a 15% reduction overall. So that's not remarkable. What remarkable we found is that particularly, even in addition to that, we found they have a significant reduction in the lipids, effect on lipemic parameters, that the low density lipoprotein, cholesterol reduction, the triglyceride reduction, that is we observe. And in addition to that, there was CRP. You can particularly know that a lot of inflammatory conditions occurs in the hyperglycemic state. You look here, 45.8%, nearly 50% reduction in the C-reactive protein, nearly 50% reduction in urinary microalbumin. So these are very important. Why? And if you correlate these parameters with the cellular damage, I will talk about cellular damage, because cellular damage, more the inflammatory process occurs in the body, the more the cellular damage. So these are the two markers we have taken to identify whether what is the effect of the particular inflammatory markers, and that is also a very important point. So we could not find that much very significant reduction. This is only a 1 month data, and but the glycemic index was much low. But compared to that, there was a significant reduction in the CRP, C-reactive protein, the significant reduction in the urinary microalbumin also. So this is very important point, Namit bhai, and you must have seen also. So, and what again, we have decided the dossier, and we looked at the effect of all of the parameters like the alkaline phosphatase, SGPT, bilirubin, like for BUN, creatinine, by insulin level, all CBCs, all parameters have been studied up to 60 days. And there was no interactions, no toxic effect of the drug. The dossier is 250 milligram. So again, in the diabetic, particularly in Ayurvedic also, the dossier is very important. Here we first of all identify the compound which is more effective, which is not toxic, which is not no toxic to the organs, then the dossier, which dossier to be taken. So also we found out that 250 milligram you can take before meal, but the maximum one can go up to 2 gram. So we made the tablet of 250 milligram, given 2 tablet before meal, 2 tablet in the morning before lunch, 2 tablet in the evening before dinner, and then we looked at the parameters of the tissue damage, the DNA damage, in addition to all the biochemical markers which we routinely look for, like the fasting blood sugar, postprandial blood sugar, the glyco-HB. Even we looked at the protein glycation effect. So what we surprisingly we found that, but this mamejo works on the glycation. So that is how, in compared to the reduction in the fasting and postprandial blood sugar, we found more significant reduction in the average, the glycation, the hemoglobin glycation, so and protein glycation also. So that is why I would stress more to effect of the mamejo is the adjuvant therapy. Why adjuvant? Because it may not have a significant reduction on the blood sugar level, but it has no interactions with the other the sulfonylurea or metformin. So you take this as a adjuvant therapy. So this will have an add-on effect, like it prevents the cellular damage. And I think Dr. Nanudai will tell more detail the what are the damages occurs in the diabetes and what are the limitations of the allopathic drugs and how the Mamejo helps in that cases.
That's right, Jayesh bhai. What is important is that when we talk about the allopathy and the Ayurvedic medicines, they are the complementary system. They are not the rivals. You cannot uh, compete with the allopathy for reduction of blood sugar, and the benefits of the Ayurvedic molecules are different and different ways. So I think when we talk about the good, our time tested Ayurvedic molecules, then they can be combined in those patients who have an allopathic medicine. The, the problem one is that when we talk about the complication of diabetes, all of you know that diabetes complication depends upon the duration of diabetes, the control of diabetes, glycemic variability, and lifestyle changes. There could be microvascular complications, there could be macrovascular complications, like macrovascular complication, heart disease, coronary artery disease, brain, carotid artery disease, and peripheral vascular disease, where Pranav Bhai said about the amputation. While when we talk about the microvascular complications, then they are related to your eyes, retinopathy, the nerves, neuropathy, and the third complication, which is very dreadful, is kidney involvement or the nephropathy. So these are the two sets of complications which are very important. When we talk about the complication of diabetes, then it is the microvascular complication, which is solely because of the duration and the control. But macrovascular complications are because of diabetes, lipids, blood pressure, plus most important thing is lifestyle changes like obesity, a sedentary lifestyle, smoking, alcohol, stress, negativity, everything, I mean, obsession, they put it together and produce macrovascular complications. So these are the drugs, the Ayurvedic drugs, which can be helpful in a certain extent, where once you have, suppose, microvascular neuropathy, you hardly have anything to treat the neuropathy. What you can do is a symptomatic treatment of neuropathy. Once you develop retinopathy, when there are aneurysms or hemorrhages or proliferative retinopathy, then you cannot reverse back. You have to treat them with
Now,
laser
Madhukar,
photographs.
I would like to think, bring one point here.
Yeah,
With
please.
this, particularly with the anicostimal mamejo, tried in the rabbit and they found that particularly rabbit developed the retinopathy. There was this reduction in retinopathy, and we found out that I think 2 or 3 patients who comes to our clinic but who had a retinopathy, and they continuously take the Mamejo now, the significant improvement. So I will tell publicly that those who have the earliest signs of the retinopathy, diabetic retinopathy, they should start taking the Mamejo in the 250 milligram, and that is really helpful for them to at least prevent the further progress of the retinopathy.
That is the point where I was going to talk,
Okay.
that the once you have retinopathy in a diabetic population, with allopathic drugs you cannot get rid of retinopathy. You can reduce the incidences by good glycemic control, but at the same time, these drugs, Mamejo or the anacostyl will help you to further prevent the retinopathy, and if it is in early stage, it can reverse back also. That is very important. So those complications which are not treated by many of the drugs, and we have only symptomatic treatment in allopathy, this compound would be useful in prevention of the development of these kind of complications along with the anti-diabetic management through allopathy. So that is the whole story, that it is a complementary medicine. We must understand the drawbacks and the efficacy of both these systems and how you can combine these two systems where one system potentially beneficial effects of the other system. So we still have to do, because these are the studies which are small kind of pilot study. There are many things are left out, and we cannot even with this kind of compound do a study where the multinationals are doing randomized double blind control trial is not possible, because there are a lot of funding which is required for those
Lot of
kind
money.
of studies. So
Even this study, yeah.
it is not possible. So we must have to understand that how we can do still better. Like, turmeric. We talked about turmeric, but when people knew turmeric only when they knew curcumin, and then curcumin is available on Google, turmeric is not available on Google. So you have to understand these things. Now, jackfruit powder, lot of benefits were highlighted because of jackfruit powder, but nobody knew what was jackfruit and who used that. Only it comes when kind of this publicity we knew. So there are many things which can be like fenugreek seeds. They are also useful in diabetes, dyslipidemia, constipation. So we must keep an open mind to look for the complementary medicine where it can be helpful in a patient, because the modern medicine is different. It has to be patient centric and safe, without side effects, beneficial, but at the same time the Ayurvedic medicines are also patient centric, safe, without side effects, beneficial in a different way. So we have to think of this both which are complementary to each other, and we try to find out a solution to this, that scientific way to evaluate the Ayurvedic medicine and make them more popular and easily available. And as per now, the cost of the medicines are skyrocketing. This kind of drug would be very useful. Simple example, if you talk about the reversal of diabetes, what do they do? They give you low calorie. That is what we prescribe. That is the saints, the Munis were doing low calorie diet, and now we have to do this also. So these are the things which we
So
must
this is very important story I would like to tell. I'd like to tell about this low calorie diet. I know that once, I think some few years back, Sir John Bunn from UK, he came here and was staying with us in our home, and then my father was there. So we were discussing some about the diabetes, because my father was diabetic, as you know. Dr. Navneet only was treating him, and he brought some Ayurvedic book, and then he said, "Okay, look, read this chapter," and there's a chapter written that the poor diabetic should live like a saint, and then there is a slok written that the people who can't afford have the treatment, they should dig the pond, they should walk the miles, miles and miles together. In short, what was the essence of the diet? This way, and this has been written before thousands of years. We know that this was in Charak Samhita. So the Charak Samhita has not written that the people who are diabetic, if they cannot afford the medicines, you do a lot of hard work, like you dig the pond, you walk for a mile together, restrict your diet. And what we talk about the modern science, we say the same thing. After thousands of years, we spending millions of dollars research, we say the same thing that you can reverse the diabetes. How? You just restrict the low calorie diet, restriction in the diet, you do exercise. So and that paper has been published. It's some people can read that, they give the words, poor diabetic patients should live like a saint. That is the title of the paper, has been published in Diabetic Medicine. Very authentic journals, or they're published from UK. Usually they don't accept such kind of the article, but I think thanks to Sir Professor John Byrne that he was there, one of the author. My father also, though he is not a scientist, he was also one of the author, and then we quoted that how what is written, what we talk in the modern science, that is already known that this is what one has to do for type 2 diabetes.
That's right. We can talk about these things for hours together. Absolutely very interesting question, because how often one should check the blood sugar, whether it should be checked with the glucometer or whether it should be done in the lab, is a very important thing. Now, if you look at the science in today's time, then diabetes can be monitored with blood sugars, fasting, and 2 hours after meals or 1.5 hours after meals. The other thing is that you should look at the A1C, HbA1c, which will give us roughly the last 3 months of average blood sugar in the blood. And the third thing now, which has become very popular, is a continuous glucose monitoring system by which we can see. Now, glucometer, modern glucometers they are very up to date. They are par with the laboratory. So you can taste your blood sugar with the glucometer at, at your home. If you are a suffering with the diabetes type 1, then you should do quite frequently. Western world tell us that we should do it every day, couple of times, but usually that may not be cost effective in countries like us, developing countries. So we do 5 samples once in a week and then ask them to monitor like that. Some people who needs they would do quite frequently also. Second thing is that A1C is to be done for all patients, whether it is type 1 or type 2, to look at the glycemic control. The blood glucose monitoring for type 2 diabetes can be done once in a fortnight or once in a month, and as and when required. Now, continuous glucose monitoring, whether those patients are multiple subcutaneous daily injections or those who are on pump, they should have a continuous monitoring of the glucose system for the better control of diabetes. So, the diabetes control can only be evaluated with the help of blood glucose examination, plus minus HbA1c and plus minus CGMS, depending upon your availability, situation, cost, and other things. There is no other way by which you can find out whether your diabetes is under control, whether you don't have symptoms, whether you don't wake up in the night for passing urine, whether you are working 18 hours a day without problem, or whether you are not eating sugar in any form. These are the criteria. They do not tell you whether your diabetes is under control or not. So you have to do. One thing I would tell you, that sometimes we would like to do that glucose monitoring with the glucometer at home and laboratory. They are not rivals, they are complementary to each other. So quite often I would tell them that for emergency use glucometer, and once in a while at a regular interval go to the lab and get your test done, and sometimes cross check your glucometer with the lab readings and then find out whether you are doing right or not. So it has to be tested in a particular manner. The casual blood glucose values are not very informative about the control, but that they can tell you that whether you are running high sugars or whether you have low sugar and you have hypoglycemia and you need an urgent treatment or not.
So is it not that Navneet bhai, particularly when you look at the blood sugar with those who are non-diabetic, they should check the fasting and postprandial together. They should check HbA1c, or what exactly the guidelines?
No, for type 2 diabetes, they have to do fasting 2 hours after lunch, And here we advise sometimes 2 hours after dinner because our dinners are very large in comparison to lunch. So that is one thing. HbA1c and blood glucose are complementary. You cannot see that only HbA1c will not give you the idea of
Yeah.
day-to-day fluctuation and
Yeah.
day-to-day changing of the drug.
Yeah.
So you have to do this. And third thing, even if you are doing all these things and you still have your diabetes which is not under control, then you have to find out where the things are going wrong. And in that case, it is a continuous glucose monitoring system which in India, Abbott's Libre is available, Guardian Medtronic is available. But Libre is little more popular in the way that one sensor gives you a 14 days reading, every 15 minute readings, and then you can monitor your sugar during night time also, and you don't have to prick every time because one sensor prick would give you 14 days reading. So the importance of
Very. Yeah.
pricking and all those things, we still not at the era of non uh, injectable glucose readings. So when we will have that like oximetry and you can see the probe and see the glucose levels, then that would be very useful.
I would like to say one at one point also here that particularly for the those who are diabetic patients, they should really regularize their meal, the timing. Do you think that Navneet bhai, the timing is very important? You should be very time bound in taking your diet. Those who are type 2 diabetes, the
Yeah,
regular.
I absolutely agree. We tell them that you have 4 meals in a day because you divide your meals 4 times in a day, then your pancreas will not be bombarded with the calories with 2 meals. So I usually tell them whatever your calorie intake is in a day, you can take 15 to 20% of that calorie intake with the breakfast around 8 o'clock, then 30 to 35% with the lunch that around 12 to 1 p.m. and then at around 4 p.m. you can have another 15 to 20% that is afternoon snacks, and then you can have your dinner 7 to 8 with the remaining 30 to 35% of the calories. So if you divide these, then there would be a plateau, there would not be a very large fluctuation of glucose with the meals, and calories are equally divided, and that would be useful. So I always tell them in type 2 diabetics that you should have 4 meals roughly at 4 hour interval during daytime, and then you have to divide your meals like that because some people have larger breakfast, they can have 30% breakfast, their lunch could be 20%, then again they can divide like that, but you have to divide in 4 parts 4 hourly.
And the timing has to be fixed. It should
Timing
not
has
be
to be,
high. Timing has
yeah,
to be
that's
fixed.
true, that's true.
And second important point also what I observe, particularly those diabetic patients, when you start eating, you do not start with a carbohydrate because that may make the surge of the insulin. So I think start with the prime your body. So take some protein intake or something like that, and there you add on the carbohydrate. So that will also. This is what I observe in my daughter. Was during the pregnancy, she observed that while she takes the food, if she starts with a roti or chapati, her blood sugar the glucose blood sugar will be high, gestational diabetes she had. But modified the diet, she found that okay, if I take little bit with the cereals or some protein-based diet and then take add-on the roti, my sugar will not be that high as compared to what I start with the carbohydrate. So I think, what is your point, Namit bhai, in these observations?
I absolutely agree with you. When we talk about the carbohydrates, they have a least satiety and they have a more hyperinsulinemia after the carbohydrate consumptions. It doesn't give you a feeling of fullness, and that is why our diet, which Indian traditional diet across the South India, North India, West and East, is more of carbohydrates. We have carbohydrates up to 65 to 70% in the
Yes,
diet.
yes, yes.
And what we have, we are thin Indians, sarcopenic Indians. Our muscle mass is less, our adiposity is more. We are thin fat Indians. So our diet should be more of a protein in present scenario and less of a carbohydrate. And those carbohydrate which should be more of a low glycemic index carbohydrate instead of high glycemic index carbohydrate. And that is why when we talk about the breakfast, start your day with the protein. You know, many customers who have sprouted pulses in the diet, because the proteins will give you a satiety which can keep you full for a longer period of time. So you should have low carbohydrates, low glycemic carbohydrates, high protein, around 1 gram per kilogram. Then you should have vegetables, and you should have fruits, and then salads and all this would be included, one portion, and then remaining would be your fat. It's not that fat is totally contraindicated in you cannot consume fat. Absolutely, you should avoid the saturated fat, which is very important. And all those fats which are solid at room temperature, like butter, cheese, and the trans fatty acids, should be avoided. But otherwise, there are some good fats available in avocado or olive oil or other things which would be very good for the health. So I think a kind of modified Mediterranean diet where one fourth of a portion should be carbohydrate, one fourth of a portion should be protein, and one fourth of a portion should be of vegetables and fibers, and then one fourth would be fruits and the fat. Then you can have a balanced diet, and by which your satiety is taken care of and you will not indulge into overeating. Over to you, sir.
Wonderful, very well articulated because of your live conversation and interactions
And I would
between two
also,
scholarly experts. You covered up almost 6 questions out of 10 that we derived from the popular demands. So you already covered up what are the side effects of any medication and what modification should I make in the lifestyle. What are the warning signs that probably we did not touch upon? So would you like to share something more about what are the warning signs, symptoms of blood sugar when it is too low or too high, please?
First of all, you should know that which are the conditions where patients are likely to be hypoglycemic or with low blood sugar, like elderly patients, cognitive dysfunctions, very tight control for a long period of time, those who develop suddenly a kidney failure or a liver failure, and those patients who are on sulfonylurea kind of drugs and insulin. These are the subset of the patients who will be vulnerable to develop hypoglycemia. And why? We must know when a patient develops hypoglycemia, why he develops hypoglycemia. So you have to find out whether it was an inappropriate doses of medicine, whether he missed the meal, whether his meal was delayed, or he did an unaccustomed exercise, or he took some other complementary medicine which are also causing the low blood sugar, or whether he is developing a renal failure which up till now was not there, and that is why this drug metabolism is changed and leads to hypoglycemia, or whether his liver is affected, that produces, because liver is affected, it doesn't have the glycogen storage and it doesn't compensate the hypoglycemia, or whether he has alcohol, or whether he has some endocrine conditions like Addison's disease. So these are many things which can be responsible for hypoglycemia. So any patient who is having diabetes and on treatment, if he develops hypoglycemia, then you have to be vigilant and try to find out. The rare conditions like insulin receptor antibodies and insulinoma, we will not talk here. And another important thing is that once what are the symptoms? So symptoms will depend upon the duration of diabetes and control of diabetes. If you have a very good control, and if your duration of diabetes is long with autonomic neuropathy, you may not have any symptoms. You may just fall down or develop seizures or anything, and then somebody checks the blood sugar and finds out the hypoglycemia. But those who are compact and not a very long duration of diabetes and not very tight control of diabetes, they would have either a symptom related to their sympathetic nervous system or related to their brain. So these are the symptoms, like they may have perspiration, they may have hunger excessive, they may have headache, they may have tremulousness, and then they may have some neuropsychiatric disturbances, the things which a normal person will not do, like he will do. So these are the things which a hypoglycemic patient do. But those who have neuroglycopenia, hypoglycemia, those patients will have unconsciousness, their conscious, they may be drowsy and other things. So we must find out why patients develop hypoglycemia, and then what you should modify in the treatment and how you should treat hypoglycemia. So all patients, when they come to me, I would first thing which explain to them is hypoglycemia. If you do not follow the diet properly, if you not taking medicine properly, if you are taking, sometimes what happens, patient is planned for surgery, he thinks that his diabetes should be under better control, so he consumes one additional tablet or additional units of injections, and then he develops hypoglycemia because he's kept nil by mouth for surgery. So these are the things which can be prevented. The another important thing for hypoglycemia is, Pranab bhai, that insulin syringes we have in India. We have 1 cc 40 unit syringe, we have 1 cc 100 unit syringe. So our vials are also like that, 1 cc 40 units and 1 cc 100 units. If you interchange, if you take insulin 1 cc 100 units vial with 40 cc syringe, you are taking 2.5 times insulin, and that produces hypoglycemia. So these are the various things in practice. You have to see all those things which can produce hypoglycemia. Even diarrhea, vomiting episodes, and you still go on continuing the same medicine, you will hypoglycemia. You will have hypoglycemia. So hypoglycemia is a very dreadful complication, and we must be prepared. We
People
must
die.
be, I mean, educate the patient about this.
This is just by your take on the subject, or would you like to add on anything?
I would like to add on the things like particularly for the complications and knowledge we have already said, but give one warning signs to the all diabetic patients who are just too much propagating the Ayurveda that okay, so you just don't take Ayurveda, you take this preparation and you take this tool and your diabetes will be controlled. So there are very tall claims what we from the experience of my personal experience, the scientific studies I found, all the Ayurvedic drugs are like your food, daily food. So it has to be in a systems. So they work like an add-on therapy. They cannot work in isolation. Like somebody say, okay, I will just take haldi or I will just take mamedi or my diabetes will be controlled. No, don't believe that. Only thing they add, this is an add-on therapy, so only this helps you to reduce the complications. As I said earlier also, the people die of diabetes is not because of high blood sugar, it's a diabetic related complications. So particularly the drug which but I have the herbal drug or the Mamejo that helps you to prevent that complications by reducing your DNA damage, by reducing your chromatin exchanges. So that is how it preserves it keeps your DNA intact, minimum damage to your cellular damage. So the whole idea of this debate is diabetic patients, they continue to take your allopathy. Do not stop your like you have to take insulin or whatever you have to take the oral hypoglycemic agent. At the same time, this works in add-on therapy and it's good that this particular the Mamejo is we could not find as a very great hypoglycemic agent. So in a way, it is a blessing that it is very safe. Also, at the same time, we found very significant effect on the lipid parameters and significant effect on the tissue damage. So it prevents the tissue damage. The retinopathy is the highest one. It reduces the retin, it particularly prevents the diabetic retinopathy. So the whole idea is that you take the continue your medicines with the medical with the under your doctor's guidance. Do not become your own doctor, your own self. Or somebody says, I have taken some jambu pills or I have taken these pills, herbal pills, and there will be, we have seen that in the corona time also people making a tall claims and ultimately people have to suffer. So the biggest problem with the Ayurvedic science is that there are difficult and we need a good science like what we presented the work. There is almost about 5 years work is a but 5 crore rupees grant has been spent on that. 5 crore rupees you can understand. This is just to understand how it works. That was a very minimal study we have carried out. Larger trials still has to done. I think then the things have changed in the system, so we could not do further. But we know that this how the any drug development takes place, whether it's a modern medicine or Ayurveda, the Ayurvedic medicine has to go a systematic, the all the documentation of the parameters, modern parameters, because in modern times, if you remember the words of our Prime Minister Modi Sahib, I think very recently he said that there are tall claims in Ayurveda, but the current demand is the proof. You give us a proof. We say that okay,
Exactly. Since
yeah, we need a
I
proof, and
completely,
then and we can do that. We need to have the proof, and once we have the proof, it will have the larger acceptance globally.
agreed. I can't agree anymore. Dr. Jayashwar, very well articulated and really thoughts shared today will have profound impact in days to come. Not digressing from the subject, I would like to ask and know on behalf of the audience that how do other factors such as high cholesterol and high blood pressure affect to the patients if somebody is diabetic?
First of all, the cardiac risk, what is important in cardiovascular risk in diabetes. And if you see, all diabetic patients, they have complications which probably do not kill instantaneously or at an age which is most productive. You develop a retinopathy, you gradually have problems, and you may go blind, but that takes years. Likewise, kidney failure and end stage disease also takes time. But the heart problem, coronary artery disease, and myocardial infarction is a very dreaded risk factor and complication in the patients of diabetes. So, when we treat about the diabetes, don't focus only on glucose control. There are many things which you have to see and take care of for the prevention of complication and especially heart related complications. And that is why when we want to avoid those things, then you have to look at your blood pressure, you have to look at your cholesterol, lipids, because these are the two important things which can be managed little better with the minimum number of drugs in comparison to diabetes management. Then comes the exercise, then comes the weight reductions, diet, and addiction, and all those things will come along with these things. Then you may think about homocysteine and lipoprotein and other risk factors. But what is important that when we look at the patient as a whole, it is not the only blood sugar. You look at the blood sugar, you look at the good glycemic control, you have the least glycemic variability, your medicine should not produce weight gain, and your medicine should not produce hypoglycemia, along with the control of other risk factors that can help. And even then, there are some gray areas where you still can have heart disease. And heart problem is such that it can kill you at that moment. It can make you very, your heart pumping may go down and your competency, physical fitness may not be as good as you had. Or there are so many things, cardiomyopathy, cardiac failure, heart failure, coronary artery disease, brain related problems, stroke and other things, or amputations when the blood vessels are involved in the lower limb. So now, when we talk about the modern treatment of diabetes, it is the good glycemic control, it is the prevention of hypoglycemia, weight gain, least glycemic variability, along with cardiovascular risk factor modification, which is very important. Prevention of amputation is very important. Prevention of retinopathy is very important. And prevention of diabetes as a whole, to teach our next generation that how you can prevent or delay the development of diabetes with lifestyle changes would be very important in this situation. So, and now the drugs are also, whether they are cardiovascular safe or not. Before that, nobody knew about the cardiovascular safety. Once they found out that all drugs which enter into the diabetes armamentarium, they are cardiovascular safe. Not only that, we have drugs which are cardiovascular beneficial. Now we have some GLP-1 receptor agonist injections, and we have some SGLT2 inhibitors. They not only help the blood sugar reductions, but they help in heart disease, they help in renal problems, and that is why the newer development in the management of diabetes is related to this development, where the drugs not only focusing on glucose but focusing on cardiovascular benefits, lipid benefits, kidney protection, GFR, albuminuria, and all other things are important. Also helpful in weight reduction or not. So our things have been changed. When we new studied, we have only two risk factors for pathophysiological factor for diabetes: insulin resistance and insulin deficiency. Now we have 16 pathophysiological causes of development of diabetes, and then still it will go on, and there would be more addition of pathophysiological risk factors in diabetes.
Wonderful. Jeshbhai, would you like to add on anything to this, please?
No, I think this is fine. We have said, I think, enough about
Yeah,
the.
and that lead us to the last question of the day today. That how often should I be seeing to a doctor to optimize the diabetes management?
Those patients of type 2 diabetes, if they are asymptomatic and if their diabetes is under good control, I usually tell them that they should communicate me telephonically every month, and they should come in person every 3 months for evaluation. The type 1 patient, I would like to talk to them every week, and they should come to me every month for evaluation. So this is in our setup, our scenario, and our resources. I usually tell them like this. But then a month here or there could be possible, or we have now the communication is much better. We have video communication, we have audio communication, and so many things are available. So if they remain in touch with us, it really makes the difference.
And I would like to add one more. I think the people who are type 2 diabetes, they are on the drug. At least keep monitoring your the sugar level at home by glucometer, and once in a month, maybe in the laboratory. And then occasionally, maybe twice or thrice, you can check your average, the glycation hemoglobin. So you know your average 3 months control. Your blood sugar fasting PP will tell you, reflect your present status of the diet. Your HbA1c will tell you about your average 3 months average control of the diet. So once you have the parameters, depending on that, you have to follow and show to your doctors. Some patients I have seen that they for months together they don't go to the doctors at all. Don't do that. Regularly make a follow up to a visit to a doctor and regular checkup with the blood sugar levels. It's very important.
Wonderful. Very well said, dear friends. We are almost at the end of our program for the day. They both made a very impressive and valid point that the Ayurvedic take-home message is the Ayurvedic medicine does have a role to play as an adjuvant therapy, as a complementary therapy. Both the therapies are not in competition with each other. Dr. Jay Shet's vision, we fully endorse whatever he said, sitting far off here with Canada. I would not be able to make some bold statement like he does, but it doesn't mean I fully agree and endorse with his views in principle. And probably, who knows if this research funding is further extended, and probably the next Nobel Prize could be from India, from alternative medicine. I'm really surprised that when Michael and Dr. Roshonari got the Nobel Prize from autophagy, and Dr. Michael got really, Dr. Jayeshbhai, I firmly believe, I'm more than convinced, had there been a Nobel Prize, late Rishi Vagbhat would have been the first contender to win it outrightly, outsmartly, across the globe, because he
Yeah,
gave
that's right.
detailed dissertation, description, scientific elucidation on circadian rhythm, for which Dr. Michael and team today got. I'm truly overwhelmed and thrilled with the kind of study that you did on the Ayurvedic herb. Probably it's a Anacostina littoral is a kind of study the team did, and they found very interesting finding. Probably it could be the path breaker to the patients suffering all across the globe. with this. I once again thank you so much.
Thank you very much,
This will
Ronit.
stay on different social media. There are a lot of questions coming from, but we are running out of time. So please attend them on a one-to-one basis, and this will be documented. Stay on our library for years to come, and you would be happy to know that one of the biggest podcaster of complementary medicine has been our partner in media, Daniel Lean, and she will have a look at the presentation, and hopefully your voice will be rebroadcasted to all the radios and televisions all across Utah, California, Los Angeles, and New York. Thank you so very much again
Thank you
to
very
all
much.
the viewers for joining us. Thank you, Jayesh Bhai.
Thank
And
you, Ronit.
it's indeed a
Pranav.
treat to watch and to listen to you both. Thank you, Nonit Bhai. Thank you
Thank
so
you.
much.
Thank you, Pranav.
Thank